The chills that we feel leave me filled with satisfaction when we're done. Satisfaction of what's
Great tune to start off.
yes for another.
Morning.
Yes
Hi,
for
Brian. Hi, Alison. Hi, Andrew.
I do deeply dig, no walls, only
Emily.
myself a dish. My
Vicky. Hi,
dish,
Brian.
baby. I couldn't ask for another.
Hi, Mary Lou. Hi, Sam.
No, I couldn't ask for another.
All flooding in from various corners of the globe. Welcome, welcome, everybody. All right, DJ has chilled down. Welcome, everybody. Great to see you all. Welcome, welcome to this seminar. Thanks for the DJ there, playing us in. DJ Danielle WK in the house. Lovely to see you all. As in tradition, what we love to do is for everybody to unmute themselves, say hi, and then mute back down again. Yeah, so we all know that you're muted. So after count of 3, 1, 2, 3, go.
Hi.
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 Beautiful. Great. And if we mute back down, that would be fantastic. What's great for me to know, and great for everybody to know, is who is in the house. So I'd love it if you can put in the chat who you are, if you're new to Jing, and your interest in today, really. I'd love to orientate this according to your needs. It's also really good for me to know if you're a massage therapist, physio, a chiropractor, physical therapist. Hopefully we've partnered with Physique for this Zoom, so we've got lots of different types soft tissue workers in the house. It's always great to get lots of opinions from different sides of the bodywork field, so it would be great to see who is here. So you can stick that in the chat. And hi Rhiannon, postgraduate sports therapy student from Poole, always wants to learn more. We get a lot of that in Jing. That's great. Ruth from Gloucester, you know Dr. Foster, Ruth. Chiropractor, nice to see you. Soft tissue therapist, hi Andrew. Hi, osteopath, past bodywork beginnings. We did massive, fantastic. Eastbourne, 2 football teams. Hi Ellie May. I play football as well. Not very well, but I do play. Newbie massage show, brilliant. Okay, amazing. Oh, nicely trainee psychotherapist there. Hi, Lindsay. That'd be great. Scar therapist. Hi, Michael. Fantastic. Okay. Great to see such a mix of people in the house. Really appreciate that. What I want to say about these Zoominars is we really love interaction. So if you have got any questions, please put it on the chat. Also, I see myself here as a facilitator for different knowledge, different experience, different viewpoints. So really happy if you've got something to say that either is different from what I have to say or extra than what I have to say. Please put it in the chat. Really happy to incorporate it. So we're all here to learn. You know, I always say there's no rights or wrongs in body work. You know, there's often just lots of different evidence-based research, different points of view, different clinical findings. So really happy to welcome that all. All right, so without further ado, today is about IT band syndrome. So it'd be great to know if anybody's dealing with that as well. If you want to put that in the chat, if you're dealing with that a lot, or if you're new to the condition. So if you were here for something else, you might want to go for a cup of tea now, because this is about IT band syndrome and how to treat it. My name's Rachel. I am one of the directors at Jing Advanced Massage Institute down in Brighton, which was sunny this morning, but now it isn't. All right, so I'll share my screen. I've got a little PowerPoint here for us. So there we go. Dun, 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 dun. There we go. All right. Okay, so I will do my best to keep my eye on the chat as well, although that is sometimes challenging. Danielle will also help me as well, kind of with that, but please do ask questions as we go along. I'll try and incorporate it and also allow some time at the end for Q&A. All right, so first of all, really happy to be presenting this in partnership with Physique. wonderful partner. If you're not buying stuff from Physique, you should be. And also you can get a code through Jing. If you want to stick that in the chat, Danielle, that would be great. Really good company, sell loads of great stuff at a really reasonable price, and you can get 10% off with your Jing code. Jing 10, there you go, very imaginative, that's your code. As I say, my name's Rachel. That's my other co-director and founder of the company there on the left. That's Meg. She wears way more lipstick than me. She couldn't be here today, but she does send her love. That is the book What We Wrote. So if you haven't got Massage Fusion, you can get that from well-known booksellers, including the very write-off one, which we don't promote, but it's about £32.50, and I always say that's about the last 30 years of my head. So if you are interested in chronic pain, that lots of different soft tissue techniques and some of the different techniques that we use in Jing. And if you don't know anything about Jing, very briefly, we are a massage and complementary therapy institute based down in Brighton. We teach everything from beginners. So if you're not a massage therapist yet, if you're a physical therapist or, you know, a different type of practitioner who's not yet doing hands-on work, we start you with a really nice intro course. It's only 7 days, called Bodywork Beginnings, which teaches you a range of soft tissue basic techniques. You can then progress to our certificate in advanced clinical massage, which is a year part-time, and is also year 1 of our 3-year degree level course in advanced clinical and sports massage. That certificate in advanced clinical massage is also a sports massage qualification accredited with the SMA and several other sports massage organizations. If you're just interested in CPD, we do also do the certificate in advanced massage just as an online course, and we also do loads of other short CPD online courses as well. So we'd love to have you down at Jing for any of our courses. We do try and put out a lot of free stuff as well, so there's loads of stuff on the website. You know, do sign up for our mailing list, because we put out lots of free stuff like this, and we just really love connecting with other passionate practitioners like yourself. So great to see you who are hungry to learn. I'm going to stop that share for a moment, because before we start, Danielle is just going to show you some of the free stuff we're going to send you after the Zoominar. So as a thank you for signing up, we are going to send you a link to a page with some free stuff. We all love free stuff. So first of all, you get a recording. Did you hear that, guys? You get a recording. So often after we've done these, we get 500 emails to the office saying, do I get a recording? Yes, you get a recording. So you get a recording. Please give us a couple of days to get that up. So, you know, it won't be immediate, but it will be pretty quick. You are also going to get on the left, you can click to get the chapter of the leg, knee and foot protocol from the book. So that gives you some of the soft tissue techniques I'm going to talk to you about today, with nice pictures and nice step-by-step descriptions of the moves. You can also get half price. So our Jing Method Leg, Knee and Foot online course is usually $250. If you're quick and click on the button within the week, you can get that for $125. But if your pocket is not quite stretching to that at the moment, or you want something lower priced before you plunge into that, you can also get a shorter classroom on Achilles tendinosis for £20. Yeah, so you got a free thing on the left. You've got the book chapter, you've got something that's $125, and then you've got something that's $20, so you can buy some or all of those. And then also some of the techniques that I'm going to talk about. Physique have also kindly offered a nice bundle of goodies. We always like a bundle of goodies for 25% off. So you would get a foam roller. We're going to talk about those and whether they're useful or not, and how they are useful. Some rehab bands there on the left, different colors, different strengths. Spiky ball, again, that's something we're going to talk about in terms of treat and trigger points. And a nice pack which does hot or cold, which is pretty cool. All right, and so you get that as a bundle, and you get £25 off. All right, so yeah, so again, that 5-second And that is one of you. There we go. Great. Hurrah. That was good, wasn't it? That was good. Okay. So I'll go back to the subject in hand. All right. So that was your bundle. Right. So we are going to start off with a bit of musculoskeletal mastermind. So fingers on the buzzer. Actually, you just have to have your fingers on the chat. And I'm going to give you some questions and you can let me know whether you think these are true as false. We always say in Jing, points for participating, not for right or wrong answers, right? So, all right, true or false? Number one, IT band syndrome is caused by friction. And again, just put your answer in the chat. Number one, yeah, we'll go through them in a minute. So IT band syndrome is caused by friction, true or false? What do you think? Just have a go yourself. Like I say, it's just all about having a go. We learn as much from things that we get wrong. I've certainly learned more from the things that I get wrong than things I get right. All right, cool. All right, question number two, stretching the IT band can help IT band syndrome. What do you think? I should have the mastermind tune on here, shouldn't I? It's very good. Voting is very split here, isn't it? It's very good. It's good. Good. So stretching the IT band can help IT band syndrome. Number three, foam rolling the IT band can help the condition. What do you think? We're offering a foam roller in our bundle. What do you think? Are we just kidding you? Or is it actually useful? Foam rolling the IT band can help the condition. And number four, hip muscle weakness causes IT band pain. So by hip muscles, I mean muscles like glute medius, TFL, that kind of thing. What do you think? Pollyanna, I love that your name is Pollyanna. Pollyanna Phillips, that's a great name. It's like an author's name, isn't it? Marion Stackway, that's politician's answer there. This is very good. All right, great. Okay, we do need the countdown music. Yeah, excellent. Okay, right, let's have a look at the answers then. Well done, everybody. All right, so the first one, is the IT band syndrome caused by friction? So I have to say, when you're looking at the research around the IT band, we'll look at some of it a bit during this seminar. The jury is a little bit out on this. So previously, it was very much thought that IT band syndrome was caused by friction. So we'll look at the anatomy of the IT band in a minute. But it was basically thought that as the IT band comes down the side of the leg, the point where it's felt, where the pain is felt, where it attaches onto the tibia, it was thought that, you know, the sort of rubbing back and forth of the band against some of those bony prominences was the cause of the pain. A lot of recent research by the Steckos, actually. If you don't know about the Steckos, they're kind of like I would say they're the Kennedys of fascial research. There's like Carla and Luigi and, you know, their whole family, they're great physios devoted to fascial research. It's suggested that the IT band is actually firmly attached to the bone and also the quadriceps on the side, so it can't really slide back and forth over it. So there's a lot of evidence to show that the pain is more likely due to fatty tissues being compressed underneath. However, there is some evidence that shows that there is some excursion, some movement of the IT band back and forth at certain degrees of flexion and extension, kind of 30 degrees. All right, so, you know, there's a bit of a jury's out on that one. It certainly is definitely not the main cause of the pain. Number two, stretching the IT band helps the pain of IT band syndrome. So as we'll see in a minute, IT band is not muscle, it's fascia. And certainly where it is, the IT band is very tough and very thick and fascia. And in no way, Jose, we can actually stretch the IT band. So the fascia is far too tough to be stretched by our forces alone. Yeah, this doesn't mean that we can't stretch the muscles attached to the IT band. We'll look at that later on. But actually stretching the IT band is pretty much impossible. You know, it's got a kind of tensile strength of steel. So the amount of pressure that we'd had to put on it to actually stretch it is just not actually possible. Foam rolling, a bit of a contentious issue here because, you know, people love to foam roll their IT band. If you go to the gym, that's pretty much, you know, something you can be guaranteed to see that people are doing. And I think because it hurts, it's generally thought that it must be like a good thing, right? Because it's hurty. Again, foam rolling, because of the density of the fascia on the side, it doesn't really have any effect on the IT band itself. There is some evidence that it causes some kind of short-term you know, relief from pain, which is mainly neurological, because there's so many receptors, so many sensory receptors in the fascia that's just reporting to the brain. So we might get a bit of short-term relief, but over the long term, actually, foam rolling the IT band is probably not having much effect. However, you know, we can foam roll and we can treat muscles that attach to the IT band and treat them for trigger points, which might well be contributing to some of the issues in IT band syndrome. So we have included a foam roller in our bundle because foam rolling of the glute medius, the TFL, that can be helpful, but certainly foam rolling of the IT band itself, it's only going to give you short-term relief. Yeah, so probably only worth doing it for a couple of minutes just for that sort of short-term relief. Number 4, hip weakness causes IT band syndrome. So if you look at the sort of protocols that are out there for treating IT band syndrome, a lot of them do include hip strengthening, and it's not a bad thing to include in your treatment protocols. But again, the evidence is not really clear. So it's certainly not 100% clear that hip muscle weakness directly causes IT band pain. And some studies of muscle weakness haven't been able to show much of a difference between in hip muscle strength between runners with and without IT band pain. So it's possible that some weakness of hip muscles might contribute, but it's not a direct cause. And there are other factors, sort of training progression, running mechanics, poor muscular control of the leg, that might contribute more. Yeah, so might contribute a little bit, but maybe not kind of excessively. All right. And if you're a research head and you want to go and look up some of that research, we will give you the slides as well after this. So if you do want to go and look at some of that research, then as there are some of the research items around that. All right. Any comments on that? Any surprises in that? Anything that was surprising or contentious? Please feel free again just to stick that in the chat. Okay, all right, so we will go into some of those things a little bit later. It's really nice, by the way. I'm very grateful for those of you who've got your cameras on. It's super nice to be actually talking to real people rather than just black boxes. So I do understand some of you might be at work or just like, you know, whatever, got your pajamas on. So thank you for those of you who are there with your cameras on. That's really nice for me. All right, so let's have a look at the actual structure of the IT band. So who can name the muscle on the left and the muscle on the right there? Anyone you want to put in the chat? Well done, Alison. Anyone else? Yeah. Good. Yeah. Excellent. Yeah, well done. Well done, those of you who went for glute max. That's very good. Yeah, so the muscle on the left of your screen, is your left the same as mine? Let's check. So this muscle here, this muscle, you're quite right, is the glute maximus. Yeah, so the glute maximus actually inserts on the TFL, and then the other insertion point on the sacrum. So The IT band, yeah, is inserting down here. You get this tough band of fascia, yeah, and then these two muscles, this one here. Well done, those of you who got the TFL, yeah, so Transport for London or tensor fascia latte. I always make the joke that if I start a massage cafe, I will sell tensor fascia lattes. Those are two muscles that directly insert onto the IT band. So it's a bit like a Y. You've got the IT band coming up, sort of like the seam of the jeans, and then it actually goes into a bit of a Y at the top. Yeah. So these are the muscles that we can more directly influence through some of our kind of manual therapy and trigger point work, as we will look at after, and indeed our kind of strengthening work. Those of you said glute medius, that was a good answer. Glute medius actually attaches more kind of around here, more of a bit of a pie shaped one. We always call glute medius the jolly little all-rounder in Jing, because it wants to do all the different actions: flexion, extension, medial lateral rotation, etc., etc. All right, so if we want to look at what is actually interesting about the formation of the IT band, is we're not born with an IT band. It actually develops as we develop as humans in relation to the stresses that we put on it. So as the body develops in a baby, the TFL and the glute maximus have to contract to help stabilize the pelvis over the femur during crawling, walking, and eventually running. So as these muscles contract, they kind of generate a force down through the fascia lata, especially when walking and running. Early in the 19th century, there was an orthopedic surgeon, Henry Davis, who proposed that when soft tissue was placed under a moderate load, it would begin to remodel. So this is a bit like, bone. Same thing happens to bone. If we put that under stress, it starts to kind of remodel. And then there's another guy later on, Harold Frost. He expanded on Davis' law to note that not only does soft tissue remodel after injury, but it also displays a thickening effect when sufficiently stressed. So this is actually how the IT band develops over the course of many months and years, where we start to emerge with this thickened lateral fascia lata, which extends from the ilium to the tibia. Interestingly, I remember Robert Schleip. Robert Schleip is a very prominent fascial researcher. Lecturer I went to of his, he said that actually horse riders, people who do horse riding a lot, actually get a TFL on the inside of the leg as well, because they're putting much more strain through the adductors as they're horse riding. So there you go. And next time you get a horse rider, you could examine them to see if that is the case. So again, there's another picture of it. If we want to look at where exactly IT band syndrome is this pain right on the side, kind of on the tibia, just below the knee, and definitely on the side of the leg. What's interesting about IT band syndrome, which we often forget, is that it's actually a tendinopathy. So a tendinopathy is generally now the preferred term rather than a tendinitis. So tendinitis is seen to be a bit of an outdated term, because it has been discovered that a lot of things that we thought were tendinitises actually don't have any inflammation. So itis actually means inflammation. The first bit of the word tells you what is inflamed. So a tendinitis would mean an inflamed tendon. But actually in a lot of tendon pain, there isn't any inflammation, or not inflammation as we know it in terms of an acute injury. I'll go a bit into that later. So IT band syndrome is really more of a tendinopathy. And a tendinopathy is a bit more analogous to the sort of breakdown of the collagen in the tendon. So someone described it once as when you leave a bit of wood out in the rain and it starts to rot, so which is a bit of a horrible image, but if that's kind of a bit more of the visual than inflamed tissues. So IT band syndrome can also be known, the kind of street name is runner's knee. PFPS, anyone know what that is? Any guesses on PFPS? Another one of those acronyms that's tossed around. Any guesses? It's another type of knee pain. Yeah, well done, Stuart. Yeah. patellofemoral pain syndrome, FFPS. So it is called runner's knee, but patellofemoral pain syndrome, which is a bit different, we'll look at that in a minute, is also known as this as well. So if someone comes into your clinic and says that they've got runner's knee, again, you want to be checking out where it's actually coming from. So as we said, iliotibial band reinforced band of fascia stretching from the TFL and glute medius and down to the lateral tibia at its distal end. And it is generally thought to be an overuse injury, which is generally thought from the research, either due to friction of the lateral epicondyle of the femur when the knee passes through 30 degrees deflection, or compression of the fat pads, and or there is a bursa there at the same location as the knee flexes. And the structures involved, you know, we just talked about. Signs and symptoms with IT band syndrome tends to be more of a bit of a sudden onset. So it doesn't come on gradually. There's a little bit more of a sudden onset. Pain's definitely on the lateral side of the knee. The pain may radiate proximally, that's towards the head, or distally towards the ankle. And it's definitely aggravated by continued activity, especially running downhill or climbing stairs, although generally that syndrome, it's more running downhill, and that tenderness at the lateral epicondyle of the femur. The causes, most likely ones, are overuse. So it often happens when people have suddenly increased their mileage for running, or excessive hill training, particularly downhill, sometimes endurance running. So lots of running, basically. And as we know, runners love to run. Those of you who are treating runners, one of the challenges often of treating runners is they love to run. So it's quite hard to, you know, wind, sort of sometimes decrease so the body can rest enough. As I say, you know, the evidence is quite conflicting. Also, there's just a lot of general stuff out there on the internet that hasn't really got a lot of evidence behind it. So poor biomechanics is often cited. Again, the evidence is inconclusive, I'd say. Weak hip or gluteal muscles, weak hip rotators, weak inner quadriceps, weak core muscles, poor foot arch control, worn out or unsuitable running shoes. So what you often find, I mean, I do think we'll look at this in a minute when we actually look at chronic pain and the biopsychosocial model. But a lot of the research around IT band syndrome and sporting injury often really focuses on these biomechanical factors. But as we will see, often in chronic problems, there's less research out around the biopsychosocial model, because it's much more difficult to, you know, measure really scientifically, and causes are not always due down to these biomechanical factors. A bit more intel, 5 to 12% of runners get it. It's probably an underestimate, isn't it? 50% of all overuse injuries in cyclists, yeah. So runners, cyclists, and it's the most common lateral knee running related injuries. So you are going to get it a lot. As I've said before, you know, it's reasonably unlikely that the IT band is sliding over the lateral epicondyle, as it's a thickened part of the lateral fascia, which is firmly connected to the linea aspera via the intermuscular septum. It might well be actually that there are sort of two different types of IT band syndrome. So one could be like irritation of a cyst or a bursa, and the other one could be compression by the IT band of some of those connective tissues. Orthopedic assessment. I mean, to be honest, I've never found IT band syndrome that difficult to sort of, you know, diagnose, if you like, or to assess that somebody's got it, because the pain is very obvious as being at the side of the knee in a particular place. The classic orthopedic tests for it, and again, these are not 100% reliable by any long chalk, but the orthopedic tests that are classically carried out is something called the Noble compression test. So with this one, you get the knee to extend from 90 to 30 degrees, as the IT band is compressed at the lateral femoral condyle. I'll show you a picture of that in a minute. That'll make more sense. And the Ober test. So they look like this. So the Noble's test. So you get your client supine. It's not a prerequisite to have bulging biceps like the examiner there. And you palpate the lateral femoral condyle. So that's the bony bump on the femur, just on the outside. You could probably feel it on yourself, actually. If you sort of go to where your knee is and then go to the outside, that's a lateral bit, you'll probably feel a bony bump. So you'd be compressing that, and then you basically flex and extend the knee. So that's reproducing. Remember, it was said that it was that kind of 30 degrees of flexion, wasn't it? And if that causes pain, the test is positive for IT band syndrome. So that's one of the classic orthopedic tests. And the other one is called Ober's test. So this is basically where you're getting the client in the sideline position so that their upper leg can extend over the table and you are pressing down towards the floor. So many of us would just know that as a stretch for the glute medius or stretch for the sideline hip abductors. Yeah. So again, if that causes pain, then that is thought to be positive for IT band syndrome. However, as I said, they're not 100% reliable. And in fact, there was a bit of research done in 2016 on the Ober test. So that's that one that I just showed, which suggested that the Ober test, rather than assessing tightness of the IT band, actually assess tightness of structures proximal to the hip joint, such as the glute medius and minimus muscles and the hip joint capsule, rather than the IT band. So actually, it's not really assessing anything to do with the IT band. And again, the jury's out as to whether the IT band is actually tight in IT band syndrome. No study to date has actually correlated the findings of the Ober test with IT band friction syndrome, and there's no correlation between a positive Ober test and the occurrence of IT band friction syndrome in female college athletes. A study by Hamililor in 2007 actually found that runners with IT band syndrome had looser IT bands. So they actually elongated more when subject to an external load and elongated more rapidly when running. And Fredrickson found out that athletes with IT band syndrome have a tight IT band, although the Ober's test is not sensitive enough to detect it. So that actually found the opposite there. So again, you know, do they have an IT band, tight IT band or not? You know, like, who knows, and how relevant is it? Stuart's asking about client with IT band syndrome, but also has got very high foot arches. Could the high arches be a contributing factor? It has been put out there by some of the research around kind of foot position, you know, like overpronation or high arches. You know, again, you know, it's a factor to consider. It's generally not kind of the only thing that's going on, particularly in chronic IT band syndrome. I think when we talk about biopsychosocial model later on, we'll see that there might be other things that are relevant. So yes, maybe a bit, but certainly don't be focusing on that as the only kind of way of looking at your client condition. I think, I mean, those of you who sort of follow me and follow the Jing method will know that I am of the view, after looking at the research, that along with you know a lot of the sort of other thinkers of our time at the moment, that structural factors probably contribute less to musculoskeletal conditions than we've thought. I'm not saying that they are totally not contributing, but they're certainly not the only thing that's going on, and they often lead us to ignoring other things that are going on for our clients within a biopsychosocial model. So no harm in looking at them, but don't focus on that in relation, you know, and ignore other things. Just a quick thing about distinguishing IT band syndrome from patellofemoral pain syndrome. So IT band syndrome definitely on the side of the knee. Patellofemoral pain syndrome often feels more like it's kind of under the kneecap. Yeah. and some other differentiating factors. IT band syndrome, the epicenter of the pain's on the side of the knee, whereas patellofemoral pain syndrome, the epicenter somewhere under the kneecap. IT band syndrome pain tends to be worse when descending the stairs or hills. While patellofemoral pain syndrome pain tends to be worse when ascending stairs or hills. IT band syndrome doesn't hurt to do a deep knee bend or a squat, whereas patellofemoral pain syndrome, doing a deep knee bend does hurt. And IT band syndrome, pain's not particularly affected by sitting, where it's clearly aggravated by patellofemoral pain syndrome. I adapted that table, by the way, from a great ebook. There's a guy called Paul Ingraham who runs a website called painscience.ca. He's really great and summarizes a lot of the available evidence in a accessible way, and he's got some very affordable ebooks on different subjects, so definitely recommend them. He's often my go-to source for looking at research the first off, just because he writes about it in a very kind of accessible way, so I definitely recommend that. That's painscience.ca, Paul Ingraham. All right, so now we know what IT band syndrome is. We're going to start to look about, sort of like treatment. So, I mean, those of you who kind of, are familiar with Jing and the Jing method, I think once you start kind of looking at how we treat musculoskeletal pain syndromes, I do still think that we are a bit stuck in the dark ages. I've got a picture of the washing machine there because apparently I can program my washing machine from my phone. Not that I've ever done that. And, we can send a text message across the other side of the world. But actually our treatment of musculoskeletal pain often seems quite archaic, really, if you look at sort of what's out there. And I do think that kind of part of the problem is that we know that all pain, and particularly chronic musculoskeletal pain, is very heavily influenced by a biopsychosocial model, which actually means in some ways that we have to treat everybody individually. It's also much harder to get evidence, around biopsychosocial factors. So, really, I think that, with good musculoskeletal treatment, we absolutely need to be looking at evidence-based research, but we also need to be aware of the biopsychosocial model, not putting so much emphasis on some of the structural factors that have been emphasized in the past, but also looking at psychology, social factors, as well as those things like biomechanics and body posture, etc. The biopsychosocial model. Those of you who've heard me say this about many times before can go off and have a cup of tea, but if you haven't, the biopsychosocial model, originally developed by a guy called George Engels in the 70s, but known to, most of us, people have been around for a while. You could also call it a holistic model. So it's not a new model. This is something that's been around for thousands of years. The biopsychosocial model, I think, is increasingly getting adopted in medicine, and also certainly musculoskeletal medicine. But the idea is that all pain, and indeed all illness, is a combination of three factors. It is not just about the biological factors, or in our cases, what are the issues in the tissues. Yes, in IT band syndrome, there are issues in the tissues, but there's probably other things going on as well for the person. And those things do include the psychology and also the social context, and we have to deal with those. We can't just be like, I'm just going to deal with the tissues because you are doing your client a disservice. We have to know that all pain is a combination of these three factors. So the biopsychosocial model, so all health, all pain. The bio bit means the biological components of the pain condition, such as disease, tissue damage, or abnormalities of structure. And our prevailing biomedical model of health usually assigns these components primary importance, but they are just one piece of the puzzle. So in musculoskeletal medicine, we get really obsessed with, you know, the anterior pelvic tilt or the posterior pelvic tilt or gnu varum or the gnu valgum, or, you know, all these kind of things, whereas we're blithely ignoring the fact that you know, our client's been through a nasty divorce, or they've got a history of trauma, or any of these kind of things. And actually, all of these things are really important in chronic pain. Yeah, chronic pain is as much about what's going on for the client psychologically and socially as it is what's going on in their tissues. The psychological bit, there is a whole chapter in the book around chronic pain, which I recommend you read, particularly if you want evidence around it. So we know unequivocally from neuroscience that emotions, beliefs have a strong effect on our perception or experience of pain. So with emotions, there's a complex and often self-perpetuating relationship between pain and emotion. So depression can lead to episodes of chronic pain, and chronic pain can lead to depression. Pain-related beliefs. So our belief about the pain condition has a huge effect. And things called catastrophizing. So if you're dealing with somebody who's had a pain condition for a length of time, it's much more likely that some of these psychological factors are kind of perpetuating the pain condition, if you like. So we do have to be sort of on the lookout for them. You know, this again is one example of how people can get themselves into psychological or physical vicious circles. If you've got someone who's a runner, they get a pain condition, they start to avoid activity, then they get more pain because they're exercising less, and then they avoid activity more, you know, and then we actually get into more pain. Yeah. And also there's a psychological knock-on effect for that as well. If we're not doing our preferred activities, you know, that can also lead to you know, depression, which in itself we know can increase those feelings of pain. Social factors are another factor that strongly affect chronic pain. Unfairly, pain favors social groups, you know, including the poor, anybody who's similarly disadvantaged. You know, the Black and minority ethnic community experience more chronic pain than white people. LGBTQIA community are more likely to experience pain. You're more likely to experience chronic pain if you've got lower education, low income, and you're unemployed. Yeah, so we just have to know that pain is not a straightforward experience for anybody. There's a lot of science around this. So there's some guys called Melzack and Wall who developed a great theory around pain. In 1999, they put out a theory called From the Gate to the Neuromatrix. That should give me an excuse to put a picture of Trinity in there. And this actually emphasized the role of the central nervous system in perception of pain. So just so you know, Butler and Mosley, they're the more recent researchers who have emphasized the role of the brain in pain. So the brain decides whether something hurts or not 100% of the time, with no exception. Yeah. So our brains are as much involved with pain. Our thoughts, our feelings, our beliefs around the pain condition are as important as what's going on in the tissues. So in a nutshell, what this means is that our old model of pain on the top left meant that, you know, if you hurt yourself, you put your phone you put your foot in the fire. There was a one-way transmission of pain signals from the foot to the brain, and you experience pain. However, we actually know that now through modern neuroscience, that yes, there are signals sent to the pain if there is a danger to the tissues. However, our brains have all these things going on: prior experiences, attention, mood, neurochemical and structural changes, genetics. And that means the brain can actually send signals back down, which can actually modify that pain experience. Yeah. So actually what that means is your client's beliefs around their pain condition are as important as what's going on in the tissues, particularly if that is a chronic situation. And the more you have, the more clients are in pain, the more those nerve pathways are sensitized, and the more likely the client is going to be experiencing more pain. And this is called something called central sensitization. And that's a bit like where the spinal cord and the brain act like a faulty amplifier and actually turn up that volume of the pain signals. So what does that mean for you as a clinician? That might mean that you have 2 people with IT band syndrome, and it might mean that according to what's going on for them psychologically and socially, you know, one of them might take 6 months to get better or might never get better, and the other one might get better in, you know, 4 to 6 weeks. So we cannot negate what our client is presenting to us in terms of their thoughts, feelings, and beliefs. And particularly if you do work in any sort of chronic pain, this central sensitization is a feature of all of these conditions: back pain, disc pain, whiplash, carpal tunnel, residual sporting injury, frozen shoulder, headaches, TMJ, fibromyalgia. I don't know about you, but this looks like my caseload. Yeah. So if you're a massage therapist, basically you're dealing with, or any soft tissue therapist, sports therapist, you are dealing with client psychology as much as you're dealing with what's gone wrong with their tissues or whether they've got an anteriorly or posteriorly tipped pelvis. All right, so what does that mean for you as a therapist? So top tips for working in a biopsychosocial model. First of all, you really need to develop a strong therapeutic relationship with your client. So whether you're treating IT band syndrome or headaches or you know, any other sporting injury, if you develop a strong therapeutic relationship with your client, whatever you do, you're going to get them better quicker. Yeah. And there's evidence to show this. So again, you know, there's a whole chapter in the book on this. So studies have shown that a positive therapeutic alliance, so that means the sense of whether your client actually likes you and gets on with you, has shown that that's associated with improvements of outcomes in low back pain and increased treatment satisfaction for clients with other musculoskeletal problems. So we can assume that this would also extend to other musculoskeletal conditions. Yeah, so that's good news. If you've got a good relationship with your client, whatever you do to them, they're probably going to get better quicker than if you don't. Really take your time to do a thorough and holistic assessment process, you know. So sometimes I think practitioners skip over this bit. At least half an hour on your first consultation to really do a really good all-round you know, consultation. There's a little bit of research that I quote there, where clients were receiving placebo acupuncture. This was for irritable bowel syndrome, but they were randomly divided into 3 groups: a waiting list condition, a limited interaction, or augmented interaction. So in the waiting list group, the patients had no interaction with the acupuncturist. In limited interaction, the acupuncturist introduced themselves and said they knew what to do. And in the 3rd group, they got a 45-minute consultation. They were all given placebo acupuncture, which basically meant that there were needles put in to different points of the body, but not on the sort of, you know, the acupuncture points, if you like. Interestingly, obviously, the ones who got sort of the full consultation actually showed an improvement in symptoms, even though they hadn't received any sort of like real treatment, if you like. So do take that time to you know, really talk to your clients, and make sure that you assess the influence of psychosocial factors in the pain condition. So this is one way of looking at, we call them yellow flags. So we've all hopefully heard of red flags. Those are things like numbness and tingling down the legs or constant enduring pain. A yellow flag is how we assess psychosocial factors, and you can remember these by the A, B, C, D, E, F, W mnemonic. So that's attitudes, beliefs, compensation, diagnosis, emotions, family, and work. Again, if you want a bit more intel on that, there's some good stuff in chapter 4, chronic pain. There is also a sheet that you can download from our website that gives you tips around questions to ask, so you can assess what's going on for the client in terms of psychosocial factors. I mean, basically, if you pick up that there's a lot of stuff going on for the client in terms of anxiety, depression, they haven't got a good family situation, they hate their job, they're doing something called catastrophizing, so they think they've got IT band syndrome, they're never going to be run again, and running is the only thing that helped them with their mental health. If you pick up there's a lot of yellow flag factors, then you really need to be working on helping them much more with the self-care so they feel empowered, bringing down some of those catastrophizing thoughts in how you talk to them about the condition. And also it might mean there's a longer treatment progression for getting them out of pain than if there are no yellow flags going on. Really watch your language. I can't emphasize this enough. You know, what you say to people, you know, has a real effect. In neuroscience, you know, they call some language like sticky labels. Yeah. So, you know, people with problems with their knees think they've got arthritis, or they think they've got this, that, and the other, or, you know, they knew someone had ITB band syndrome and they never run again, or, you know, whatever. So, you know, you just have to be, you know, reassuring, really calm, you know, reassure the person that you've worked with similar conditions and, you know, they were able to get better, you know, so really look at how you'd kind of, you know, talk to somebody. Bye, Nikki. And really emphasize any self-care measures. Yeah. So, and again, the intelligent manual therapist, you're going to be looking for the biopsychosocial model and for clues for effective self-care. So if you pick up that there are a lot of psychosocial factors going on, maybe you want to prescribe some simple breathing exercises or something like that, rather than loads of things with a TheraBand, you know. So, you know, be really kind of broad in what you're suggesting. And don't be afraid to cross-refer. Again, if you pick up on, you know, if you feel that something's outside of your remit, then don't be afraid to cross-refer to, you know, talk therapists, CBT, things like that can be really helpful. And educate, you know, so help put your client back in the driving seat, you know, educate them about the biopsychosocial model and the multifactorial causes of musculoskeletal pain, and reduce their feelings of feeling out of control. And then we'll talk a bit about trigger points in a minute. Thanks, Daniel. Daniel Dean's put in useful work by Mike Stewart. Haven't heard of him, but that's a great tip. Thank you, on language to use with patients. If you've got a reference, if you want to stick it in the chat for everybody, that'd be great, Daniel. Thank you. I mean, one of the things that we use a lot in our work at Jing, I'll talk a bit about the Jing method in a minute. What we know from neuroscience about the way the brain works is that the brain is really detecting danger rather than pain. And there's some evidence to show that trigger points, myofascial trigger points in the muscles, can be sending messages to the brain around what we call a nociceptive input. That means a nasty input, which actually can be increasing this kind of central sensitization. So that local irritation in the tissues from trigger points can be increasing the central sensitization. So actually reducing those trigger points can greatly contribute to bringing that load down. Thanks, Daniel. Sticks and stones, the impact of language in musculoskeletal rehabilitation. Thank you. I will check that one out. Put a couple of references in there. Shah has shown that trigger points contribute to central sensitization, for example, in whiplash, and Freeman did some research that load pain thresholds were associated with central sensitization, which can be immediately reversed even with a long-standing chronic neck pain. Obviously, in our work, you know, I really have found very precise treatment of trigger points to be very effective in treatment of a lot of musculoskeletal conditions. Thanks, Joanna. I'm happy to say there's some more research coming out now that is emphasizing the role of the biopsychosocial model in sports medicine. Those of you who are sports medicine people out there. So this was a recent paper that's out, Kanero Alati, I'm sure I'm pronouncing all those names wrong, Fukusawa, but very much talking about using the biopsychosocial model, you know, in treating kind of sporting injuries. So not referring for imaging, you know, we now know that MRIs are not that helpful, and exploring biopsychosocial models and delivering positive messages about pain, yeah, are really important. All right, a little bit about the Jing method. I mean, the Jing method has been developed by myself and Meg. We've been soft tissue therapists for over 30 years now, which seems astounding. But our background is both of us is in psychology and in social work. So I think the biopsychosocial model comes quite naturally to us. So these are insights that we've sort of developed through our own clinical work in terms of what's useful. The Jing method, again, we talk about it a lot in the book and our courses. It's very firmly based on a biopsychosocial model. It's a multimodal soft tissue approach. So the soft tissue work is designed to bring down that nociceptive input from trigger points and or irritation that's going on in the fascia. We do see the consultation and self-care as important as the hands-on treatment. We keep it very outcome orientated, so we're looking at once a week for up to 6 weeks treatment protocol to reduce pain. The method, we do look at the evidence-based research, but also things that we found from our own clinical experience. Again, in Jing method, we're very much looking at what I call the treatment sandwich. So really looking at that full consultation, the hands-on work and the teaching self-care. So increasingly, we're seeing that psychology is just as important as physiology in the way we work. And that's the case for all manual therapists. The techniques that are involved in the Jing method, we remember by the mnemonic HF MAST. H stands for hot or cold. We'll talk a bit about what's useful in a minute in IT band syndrome. We put hot or cold on at the beginning of the treatment. We then look at fascial techniques. We then look at working the muscles for trigger points. We also look from an Eastern approach to working acupressure points. We look at stretching any relevant muscles, and then we look at teaching self-care. And again, we look at the power of 6. All right, so if we look at the Jing method and the biopsychosocial model in relation to IT band syndrome, I love this quote again from painscience.ca. We can put a man on the moon, but we can't treat IT band syndrome. So again, if you look at the kind of treatment protocols that are out there, you know, in some ways there's nothing out, you know, we all kind of want this magic bullet, don't we? It's just like, all right, I'm going to do that and that's going to fix it. But I do think with most musculoskeletal pain, you've got to treat each person as an individual. You've got to look at all of those psychosocial factors, and you've really probably got to take a combined approach about how you approach it. More cynicism there from Paul Ingram. Although IT band syndrome is common, there are no clearly effective treatments for it, just a mess of options ranging from imperfect to completely bogus. All right. I love this tweet. It's a guy called Greg Liam, so apologies for the language, anybody who's sensitive, but I did think that this was, you know, quite a good way of looking at any kind of rehab. So the basic template for all injury rehab is to calm shit down and then build shit up. So, you know, in a sense, it's the same with IT band friction syndrome. We've really got to look at calming the nervous system down, calming those tissues down, and then gradually building back strength in some of the muscles that are attaching, gradually bringing the person back to full activity through pacing, which we'll talk about in a minute. All right, so my basic kind of treatment for IT band syndrome, what tools have we got in our toolbox? The first thing, the very misunderstood concept of active rest, right? So there, basically any kind of injury, if it's an acute injury, if it's tendinopathy, we have to rest those tissues in order for them to be able to heal or to, regenerate. As we know, with tendinopathy, it's a bit of an odd thing where the body's just not really sort of quite healing itself. And tendinopathies can go on for a long time, which is why IT band friction syndrome is a bit recalcitrant. So active rest basically means you're not going to bed for 6 months, but neither you pushing through the pain. Yeah, so it's somewhere in the middle. So do activities that mean that you are still moving, but they're not aggravating the affected area. Yeah, so we'll talk a bit about pacing in a minute. Ice, does it help? There is no massive evidence to show that it does. However, it can help the pain. People can also feel like they're, kind of doing something. So that might also help, from a neurological point of view. Sometimes it helps people if they ice, before they do an activity. So there's definitely, again, not loads of evidence around it. There's actually more evidence for heat in terms of kind of chronic pain, but there's definitely no harm in kind of icing the area. Trigger point treatment, without a doubt, we'll look at the trigger points that might be either mimicking or contributing to the pain situation. And if we're looking at stretching, we're not looking at stretching the IT band because we can't, remember, but we can stretch, glute medius, TFL, some of those stretches around the hips. And the biggest thing for me is just, active rest, but then gradually introducing the kind of knee rotating activities. So if it's running that's affecting it, we want to gradually reintroduce the running. So pacing, I always think, is one of the biggest things that is really not used properly by manual therapists. Like, it's a really simple tool, but it's probably one of the biggest things that you've got to help your clients. So what happens in any kind of pain situation is that clients either want to do boom or bust, so they want to work through the pain, or they want to try and avoid it. So they either stop running altogether, or they carry on running and they want to run through the pain, and then they make it worse. Yeah. So pain is there to tell your body to stop doing something. So you need to get a sensible approach. You get a baseline of activity that is okay for the client. So if they were running 10 miles a day, now they can only run around the block. That's their starting point without it hurting. Get them to run around the block. Get them to run around the block for a week without it hurting, and then the next week they can run around the block twice. Yeah, but you have to help them to do this. Telling somebody isn't enough. Make them a chart. There's loads of tools on the internet. Treat it as like a plan for them, and then they're much more likely to do it. So what we're looking at is a planned progression of activity. What happens if the symptoms flare up? No problem. Just go back to how it was with the baseline that was okay. And then after a while with that, just gradually increase it. Yeah. This is also, how you'd work with more chronic conditions like fibromyalgia, as well as kind of sporting stuff. Again, this is taken from the Paul Ingram blog. Those of you who work with runners, you've probably had this conversation. Have you tried resting? Runner, yes, I really took it easy for a month. Me, did you stop running? Runner, stop. Oh, hell no, I just dropped down to 10K. Me, per week. Runner, per day. So we know we're always working with that client psychology. So, you do have to work with them as an individual. How much rest exactly for IT band syndrome? If it's a mal-new case, it might just be a few days, followed by a couple of weeks of taking it easy. If it's an average case, if it's been going on for a while, it might be a week, followed by a couple of months. If it's really severe and entrenched case, it might be a month of near total knee rest, and it might take, like a full year to tolerate athletic stresses again. Yeah. So again, it's going to be individual, and you're going to have to work closely with the person. It doesn't mean they can't do other things. Yeah. So they might not be able to run as much or cycle. Maybe they can cycle, but they can't run. So, cycling might be better, or swimming. You know, swimming's great. It's, you know, very aerobic, you know, but quite knee neutral. And if you're looking at runners with IT band syndrome, when you're building activities back up, there's some research that's shown that it's better to run shorter distances at a faster pace. Yeah. So, and there's some research to show that running slowly is worse for the knee than running fast. So less running is wise, but not slower running, and maybe just avoid downhill running. So while you're kind of building things up, they might be things to take in. Yeah, so that's got a bit of research to back that up. Running at faster paces and on a flat ground sort of limit the time in so-called impingement kind of zone. I think the thing around ice, as I said, the jury's out as to what actual inflammation is going on. So probably the IT band is not really inflamed. There's a bit of inflammation, but it's not kind of inflammation in the classic sense, and it's more kind of degenerated. So the pain of RSI is mostly unaffected by anti-inflammatory drugs like ibuprofen. And generally anti-inflammatories are sort of not recommended generally anyway now in any kind of sporting injury. But a lot of science recently has shown that there's little or no inflammation present. And actually what's going on is tendinosis or collagen degeneration. So that's why ice is maybe not as helpful as we used to think. However, you know, there is some anecdotal evidence, as I said, you know, icing, it does reduce pain. Some people find raw icing, ice directly on the skin, helpful, or icing after running if it's hurting, you know, maybe it stimulates tissue healing. There's a little bit of research around that. So, you know, I think not to be totally discounted, you know, again, might be one of the tools in your toolbox that you try with people. A little bit about trigger points. Those of you not familiar with trigger points, they are quite a fundamental part of the Jing method. They are important because they can mimic IT band syndrome. So there might actually not be tendinosis in the IT band. It is not unlikely that they could cause IT band syndrome. So we know that if we've got these kind of mini micro contractions in some of the muscles connected to the IT band, maybe they are causing some element of tension on the IT band, which is contributing towards that friction at the end. Or certainly they can complicate IT band syndrome. So if you've got IT band syndrome, they're in pain, then you can get trigger points in the area, which then report danger signals to the brain, which cause that kind of wind up. So I definitely say that treating trigger points is going to be helpful. I'll answer your question in a minute, Hannah. What trigger points should we treat? So, you know, glute medius, you know, that's causing pain more into the glutes, but that might be one of the trigger points that's involved, but you're probably more looking at these. We've got hamstrings. I mean, that's more down the back of the leg, but can sort of refer into the knee. Vastus lateralis. So don't forget that the vastus lateralis actually, you know, lies deep to the IT band. So one of the quads. So these can really be mimicking the pain of IT band syndrome. Glute minimus, which is quite deep in the hip, that can send pain down the outside of the head, so outside of the leg. Piriformis can cause pain down the back of the leg, and certainly TFL can send pain. Yeah, so any of those might be contributing to pain. In the leg, knee and foot online course that you're going to get for half price, we show you how to treat all of those, I think, in the leg, knee and foot protocol. There's one that's close up, tensor fascia latae, you can see is causing that pain down the leg. All right, there's some pictures of you if you didn't know where they were. Stretches, we always say in Jing, after you've treated muscles for trigger points, you want to stretch the muscles. Don't do that before. So static stretching or active isolated, again, in the online course that we're giving you for half price, you will get to see PNF, active isolated and static stretching of all of these muscles. So you definitely want to be looking at glute max, medius minimus, TFL, piriformis, quads, and the hamstrings. So we're really just looking at releasing any tension in any of the muscles connecting to the IT band. Foam rolling, you can't lengthen the IT band, but you can work on those muscles around it. So focus more on the TFL, more at the front of the hip, and the glutes than the IT band itself. And you definitely don't want to be looking at that no pain, no gain kind of philosophy. But it can be helpful to treat those muscles attaching to the IT band rather than the IT band themselves. And strengthening exercises. So generally we'd look at strengthening once we've decreased the pain, once we've released, once we've treated trigger points, and sort of worked on those psychological factors. But mule kicking the knee, so that's the one where you're kind of on all fours, and then you bring the leg up. And clamshells, so those are the ones where you're lying on your side, and then you're kind of opening and closing the legs. It's quite easy, these days with the internet, just to sort of look those up. And again, with strengthening exercises, you want to be doing that in progression. The rehab bands that you're getting in your bundle from Physique, if you go for that, with that one, you can use those progressively to increase the load on the muscle. So, that's quite a useful thing. So with the clamshell exercise, they would just have a TheraBand to band both legs, and then you'd be working against some kind of resistance. Yeah. So a couple of other things that might be helpful, maybe, training shoes if they're a bit knackered. Taping, or a knee brace. Again, evidence is out and how helpful it is, but I do think that the taping does provide some good kinesthetic kind of feedback to the brain about what's going on, and can reduce a little bit of the tension there at the insertion point. So again, and I think, in general, my recommendations are that we just need to be really working on all aspects of that biopsychosocial model. So, you really want to be looking at, the issues in the tissues with fascial work, trigger point work, maybe a little bit of taping, because that will help kinesthetically, some strengthening, but also looking at those yellow flags and those kind of like psychosocial factors as well. All right. Let me look at Hannah's question. I've climbed with chronic ITB. There is a painless audible clicking on the outside of the knee that happens with every step. Yeah, I mean, clicking, to be honest, Hannah, is generally like, tissue kind of snapping over kind of on the outside of the on the outside of the knee kind of thing. So often that might actually just be the band rubbing over the sort of femoral kind of condyle. Again, just reassure them that it's fine, nothing to worry about. Again, you just want to reduce any of that kind of catastrophizing in terms of how they might be feeling. So we would love for you to come hang out with us. So we've got loads of hands-on courses, do loads of stuff. So call us. We've got friendly Nina on the line. 01273 628 942. We're probably like the last organization where there's like a person on the end of the line other than the chatbot. It's a real life human being who will give you real live human feedback about your needs. Check out the loads of free stuff on the website, jingmassage.com, and or email us. Yeah. So we would love to see you on any other things. All right, any questions before we sign off? As usual, I've gone over time, but thanks for you, those of you who stayed with me. Good. Really happy if anyone's got great. Glad you enjoyed it. Great. We're doing some more stuff with Physique. You got any dates or anything, Danielle? Got some more things coming out. We do have an Instagram account. Yes, follow us Facebook and Instagram. Yeah, we're there. Yeah, we're doing loads of stuff. Oh, good. Glad you enjoyed it. Great. Amazing. Thank you. It's really lovely. I really appreciate that. We would love to see you. If you want to give us a review on our Facebook page or something, I don't know, tell them something they can do, Danielle, if they want to
Yeah.
say thank you.
You can find us on Instagram at Jing Massage. Same on Facebook. If you just search Jing Massage, you'll be able to find us. We've got 2 more of these Zooms coming up with Physique. So the next one is the 18th of July. That is going to be around treating rotator cuff pain. The next one after that is in September, 19th of September, post-herniated disc treatment. So I'm just going to pop a little link in the chat. They're both available for you to register now. And you will be sent an email with the recording over the next few days. So the recording and all the offers and everything should land in your inbox tomorrow or the day after.
Yeah, amazing. And if you want more stuff like this, we also have a membership program called the Jam, which is only $29.99 a month. Some of you here are on it. And there's literally hundreds of, it's like Netflix for massage therapists. So there's like hundreds of hours of recordings of me and other amazing guest speakers talking about stuff like this. So cost of living crisis, it's probably like the most affordable place for CPD you can get now. So we'd love to have you on that as well. Really friendly space, and there's a private Facebook group as well. Other things we've got coming up at Jing, we've got a research conference on the 20th of July, which is by donation only, just pay what you can afford. That's all our new BTEC graduates sharing their research on really different important things. We'd love it if you could come and support them. We're one of the, I think the only massage school, certainly in the UK, that's doing evidence-based research and push our graduates to do it, doing a degree level course. So we'd love to have you on that. Yeah, we're doing loads of stuff, ACMT, the year's course. We do a 3-day foundation course if you want to learn trigger points, fascial stuff. Oh, and I'm teaching on a 7-day myofascial intensive, which I'd love to see you all on in June. And there's a hot stones course on pregnancy and like loads of stuff. So just call Nina on 01273628942 and she will tell you about anything, and you will get like an old-fashioned human being telling you what we do. You guys are great. And if there's other things you want us to do Zooms on, just let us know. We're really happy to share things with the community. Yes, we would love to do that. All right. Okay. All right, guys. Michael's asking if there's a certificate of attendance for CPD. Don't know. Is anyone at Jing HQ able to answer that?
Yeah, there's no certificate available, but you can log the hours.
Yeah, you can log the hours. So, all right, great. All right, thanks everybody. Really appreciate your love. That means a lot to me. And see you on the next one. See you soon. And yeah, tell other people about us. We really like it, and keep on doing on what you're doing. And well done for turning up for CPD, because that is what makes you successful, and people need you. All right, so go out, do good stuff, and see you next time. You all are awesome. Bye, guys.